Thank you and greetings to each one of you. COVID is similar to tsunami. Tsunami strikes for a couple of hours and passes off, leaving behind a trail of destruction, loss of property, lives, and livelihood. So does COVID, which leaves the body within a couple of weeks, but has devastating impact primarily on the lung, heart, and brain. Globally, the confirmed cases are 480 million with 6 million deaths, while in India, it's about 43 million with just about 500,000 deaths. Mild COVID-19 causes very mild symptoms like fever, cough, and shortness of breath, some tiredness, muscle aches for weeks and months. Severe and critical disease are characterized by dramatic and life-threatening symptoms. Amongst these, the most common is fibrosis causing pneumonia, which quickly progresses to ARDS. Conditions like pneumatoceles, parenchymal air-filled cysts, aspergillomas are easier to handle. The second critical point is pulmonary venous thromboembolism requiring anticoagulants with the complication of intrapleural bleeding. Moreover, these patients often develop co-infections which lead to further complications such as empyema and septic shock. Important to remember is that these issues are not limited to patients who suffer from severe COVID. It can also happen in those with milder forms. When localized, a surgical approach can be considered. However, published data reports high early postoperative morbidity and mortality, and so many experts advise against surgery. The COVID Surgical Collaborative Group, which analyzed patients who were going in for non-thoracic surgical conditions, found a mortality of 23.8% and developing pulmonary morbidity rate with complications of 51.2%, all are different, touching the lung and the COVID lung. In the absence of solid data and recommendations, there are more questions than answers. This is a demanding challenge for thoracic surgeons. Why surgery? Who is the candidate? Which and where to do? When to operate? What is the outcome? Current lack of evidence or precedent hampers patients who may benefit from surgery for post-COVID lung complications. There is silver lining in every cloud. We had our first brush with COVID. In fact, we had to jump into the fire when a boy was referred from Rajasthan, Jalore district, in the early days of COVID-19. We had very little experience then. The boy had just recovered from COVID, inverted commas, and had a bronchopulmonary fistula. We could successfully operate on him, and thereafter we were buoyed by this success, eventually into more complicated cases. And at times we bit our fingers as well as burned them. Now, lung fibrosis is one of the main reasons for shortness of breath if generalized. Then the treatment is medical management or lung transplant, which is far and few between. If on CT scan there is localized disease, imagine, such patients may be candidates for early surgery and recovery. COVID is, broadly speaking, again, the phoenix of thoracic surgery, like tuberculosis. Almost all conditions and complications are seen in the COVID lung. The American Society of Anesthesiologists and the Anesthesia Patient Safety Foundation issued a general statement for patients who are going in for COVID-19 infected with COVID-19 for surgery. They found that diabetes was a major factor, which had a very negative influence. Pulmonary function, they found to continue to improve up to a period of 3 months. So they suggested wait times of 8 to 10 weeks for a symptomatic patient who is diabetic, immunocompromised, or hospitalized. 12 weeks for a patient who was admitted to ICU. Investigations are many: FEV1, PFT, 6-minute walk test, VO2 max, shuttle walk test, stair climbing is I find very useful. And even more useful is the ventilation perfusion scan, the 99M technician. Diethylene, triamine, pentacetic acid, aerosol lung ventilation, along with macro-aggregated albumin. Excellent, helps you to clearly define the area, and secondly, what could be the positive pulmonary function booster. The possible indications of which we have come across and had experience with a localized pneumonia, cavity, aspergilloma, mucormycosis of lung that's COVID associated, empyema, bronchopleural fistula, infected pneumatococcus bullae, localized bronchiectasis, PTE and pulmonary function. Due to paucity of time, I shall just run through this and tell more on the whys and don'ts and about COVID lung surgery. Localized infection in a patient who has recovered from COVID continues to have recurrent lower respiratory tract infections. Resection of that segment or lobe would go a long way in helping him to come back to normal life. A cavity can also be addressed. Similarly, fungus going into the cavity causing aspergilloma and its complications of massive bleeding. Mucormycosis of the lung, which normally it affects a variety of other organs, namely the skin, the paranasal sinuses, orbits, brain, gastrointestinal tract, and also the lung. A multimodality treatment approach with antifungals like amphotericin B or posaconazole before surgical debridement helps improve the outcome. In this particular case, it was by accident. We went in without a diagnosis. It was a localized lesion in a post-COVID lung, and this is what we found. So we didn't have the cover of antifungals going in, but fortunately, the patient recovered well. Death now. The nightmare of every surgeon is bronchopleural fistulas. This is a patient with post-COVID empyema, surgical emphysema, and there's another patient we operated upon, and this is the post-operative outcome. The lung, my dear friends, is very stiff in post-COVID scenario. It at times refuses to expand, and we were stuck with this patient with a continuing air-like leak and the lung refusing to expand. Now, multiple abscesses also can occur in the lung affected by COVID. This is a patient with empyema, and then we found the lung itself on the surface of many abscesses, and the surgical specimen revealed fibrosis below the pleura with a small collection of lymphocytes and intravascular hemorrhagic thrombosis, and no residual RNA was detected. BPF, we have discussed the nightmare of every surgeon, commonly seen in patients with post-COVID empyema with a ruptured lung. Pneumatococcus, that is air-filled cavities, and this is usually seen on the periphery and subpleural distribution. Sometimes the pneumatococcus can be huge and mimic large bullae, and of course, a rupture triggers pneumothorax, pneumomediastinum, and pneumopericardium. The case of infected nematocele, as can be seen on the CT scan, diffuse alveolar damage followed by necrosis of the airway walls can cause this condition. Etiologically, there is ground glass opacities along with air-filled thin wall cystic lesions. Excise this area, you're back in business. Post-COVID bulle, a word about it, is that especially this was a classical case where we went in with, after having done a CT with a BPF, but strangely, we encountered this bulle. And the entire middle lobe was replaced with multiple bulle, like somebody in theater remarked, like grapes, a bunch of grapes. And then, of course, pulmonary infarction can occur, about 2.6 to 8.9%. CT pulmonary angiogram confirmed bilateral thromboembolism in this patient, associated with multiple opacities and viral pneumonia. An iodine map images show triangular peripheral pulmonary infarction. This is the pulmonary artery, and distal to this is the infarcted area. These patients benefit by resection. Why can surgery not be offered? Keeping all this in mind. One problem is basically most of the financial back of patients are broken. Numerous tests, uncertainty leaves a patient economically drained, frustrated, dejected, and depressed. This is our small experience over the past year and a half. We did about 62 cases. We had a mortality of 4 patients and major complications 6. VATS is preferred to thoracotomy if possible. Complications were bronchopleural fistula, chest infections, sepsis, bleeding, and mortality was due to BPF and ARDS. Now, you would wonder why the mortality and morbidity was low is because we did not foray into different frontiers with patients on ECMO, patients on ventilator, or on anticoagulants. And in patients with severe PH, we wouldn't touch it with a barge pole. We collaborated our data with 5 other countries, Italy, UK, US, and we came up with this multi-central trial. And this probably is one of the largest trials. However, what we found was a number of thoracic complications can be dealt with and can benefit from surgery. But the role of surgery in this pathology is largely unknown, and many surgeons advise against any surgical referral. So there is that gray area. 83 patients, and this is where the findings. Complicated pneumothorax, pleural empyema, hemoptysis, lung abscess, infected nematoceles. At 30 days in the study, 72% were alive. It's 28% mortality. Not too bad. Re-exploration was required for intractable atelectasis, empyema, bronchopleural fistula treated by repairing the stump. The empyema was through decortication, lung resection. Hemothorax managed by toilet and hemostasis, persistent air leak, wedge resection, pulmonary infarction handled through lobectomy. So very initial stages, positive outcomes like quality of life improves, lung improves, patients can ambulate with minimal or no requirement of oxygen, thus converting them from respiratory cripples to productive humans, relief from symptoms like cough, breathlessness, hemoptysis, fever, etc. Conclusion, surgical management related thoracic complications is affected by high mortality and morbidity rates, but 72% survival seems satisfactory. Patients who underwent surgery for infective affections had significant lower risk of dying. Younger patients with no pulmonary hypertension seem to do well. PATS definitely improves the outcome. Remember, these issues are not limited to patients who suffer from severe COVID, but also are seen in those with mild infection.